Welcome to today's HealthLine webinar from the American Association of Kidney Patients, titled All About Your Dialysis Access Options. This HealthLine webinar is supported by an educational donation from Medtronic. Thank you for joining us today. My name is Jerome Bailey, and I am AAKP's Director of Patient Engagement and Advocacy. AAKP's HealthLine webinars fall under our Center for Patient Research and Education. We believe patient and care partner education is an integral part of treatment and protection of patient lives, and we work to ensure that the patient has a central role in research and guidance that are designed to determine optimal approaches and strategies for providing healthcare services, assistance programs, and access to new products and services. We built this center with the latest polling and engagement technologies so that the private sector research shaping the next generation of healthcare services, assistance programs, and innovative new treatments. We encourage you to respond to our flash surveys and other engagement opportunities that you receive via email as a member of AAKP. As the oldest and largest independent patient-led kidney patient organization in the U.S., AAKP is proud to host this webinar as a service to our fellow kidney patients, family members, and care partners, healthcare professionals, researchers, and policymakers. AAKP is a champion for full patient choice, the protection of the patient-doctor relationship, and the elimination of barriers for patient access to available treatment options. Today's program is very exciting as it features a discussion about the dialysis access, which is considered a dialysis patient's lifeline. Our presentation today will share information on the different types of accesses, factors to consider when deciding on an access, and how best to monitor the health of your access and avoid infections. Now, without further ado, let's get started. It's my pleasure to introduce our first speaker for today's webinar, Dr. Ari Kramer. Dr. Kramer is an assistant professor of surgery at Spartanburg Medical Center in South Carolina, where he has served as the principal vascular access surgeon since 2005. He provides an array of traditional and minimally invasive dialysis access options to patients with kidney failure in much of upstate South Carolina and lower North Carolina. His professional accomplishments include teaching awards, national podium presentations, educational seminars, peer-reviewed journal publications, and ongoing participation in quality improvement projects and emerging technology trials focused on improving the care for patients with renal impairment. Welcome, Dr. Kramer. I'll turn things over to you.
All right. Well, thank you, everybody. What a kind introduction. As mentioned, my name is Dr. Ari Kramer, and I am here to talk to you about dialysis access. I am, in fact, an access surgeon, and we'll cover the role of kidneys, kidney disease, types of hemodialysis, and the factors that you need to consider choosing your dialysis options. And I'll certainly encourage you to ask questions at the end. A brief agenda, as we talked about, is the kidney, its function, the kidney disease process, as well as an overview of the various types of access that we are going to be encountered and you will encounter. PD, a little bit about fistula creation, and sneak in just a little bit about some innovation that I think you'll find interesting. So to start, kidney and function. The kidneys are located just below your rib cage on either side of your spine, and they're the essential organs of the human body about the size of a fist. They're shaped like a bean, and they're hard-working factories which perform various biochemical functions. The primary one is to filter our blood and purifying it by removing waste and excess substances, including toxins and surplus water. This waste then exits our body and something we know as urine. And this process ensures that our body's internal environment remains balanced and free from harmful accumulations. Beyond detoxification, however, kidneys also play a vital role in hormone production. They generate hormones like erythropoietin, which stimulates red blood cell production, and renin, which helps regulate your blood pressure. They also convert vitamin D to its active form and assist in maintaining our bone health. So the kidneys, as you can see, are not just waste management facilities, but they're also key players in sustaining our overall health and well-being. Kidney disease can be influenced by a variety of factors, and one of these is a genetic predisposition. If you or your family has a history of kidney disease, your chances of developing it can be higher. Two of the most common health conditions that impact kidney health are diabetes and high blood pressure. In fact, these conditions are the leading causes of chronic kidney disease, or CKD, where the kidneys will gradually lose function over time. Our lifestyle choices also play an important and significant role. Tobacco use, for example, can damage your kidneys and make them less efficient. And this can also interfere with our ability to perform a good surgical opportunity for you to have and receive dialysis. Furthermore, prolonged use of certain medications like nonsteroidal anti-inflammatory drugs can potentially harm your kidneys. And when the kidney damage is so severe that they can no longer function, this condition is known as end-stage renal disease. And this is a serious condition that often requires dialysis or kidney transplantation. Therefore, it's crucial to recognize these risk factors early, allowing for prevention and effective management of kidney disease. So what is hemodialysis? Well, hemodialysis is a lifeline for kidney dysfunction. When the kidneys fail to perform their crucial function due to severe impairment, a medical process called hemodialysis can step in to help. This is a treatment that uses a specialized machine known as a dialyzer, and it is often referred to as an artificial kidney. Well, here's how it works. Blood is carefully drawn from the body and channeled into the dialyzer, but instead of thinking about the dialyzer as a simple laundry service, it's more accurate to imagine it as a high-tech filtration system, one that is finely tuned to mimic the natural functions of healthy kidneys. The dialyzer has a series of semi-permeable membranes, much like the microscopic filtration units in your own kidney. And as the blood passes through these membranes, waste materials, excess salt, surplus fluids, they're removed. And this is similar to how the kidneys selectively filter your blood, allowing the vital nutrients to remain while removing harmful substances. Once the blood's been cleaned, it's safely returned to the body. Hemodialysis, therefore, is a vital bridge to health for those living with severe kidney disease. And this really illustrates, I think, the remarkable possibilities of modern medicine. Hemodialysis has a couple of options. We have in-center and at home. Hemodialysis can be administered in two primary settings. As mentioned, the first is the in-center dialysis, which typically involves 3 sessions per week, each lasting for roughly 4 hours. And in this setting, you're in the hands of a medical professional who oversees the process, ensuring your health is cared for efficiently and safely, and it's a scheduled commitment to your well-being. The second option is in-home dialysis, providing a little bit more flexibility. This treatment can be done roughly 4 to 7 times a week with shorter sessions. Home dialysis allows you to integrate the treatment into your daily routine a little bit more comfortably and enabling you to manage your health within the familiarity and comfort of your own home. The choice, however, between in-center and home dialysis can depend on a host of various factors, such as your lifestyle, your personal preferences, and even your medical condition. Both options, however, are designed with the aim of making the dialysis process as seamless and efficient as possible, always prioritizing your health and your convenience. Prioritizing optimal health care. To perform hemodialysis efficiently and safely, we need a reliable method to access your bloodstream repeatedly. Begins the crux of our talk. We have 3 primary options for this, and each has its benefits and potential challenges. The best choice depending on your specific health condition and lifestyle needs. First and foremost, we have the AV fistula, which is commonly considered the gold standard of dialysis access. This involves creating a direct connection between an artery and a vein, typically in your arm. This method is often preferred due to its longevity, lower infection risk, and better dialysis efficiency. The method is the AV graft or arteriovenous graft. This entails connecting an artery and a vein using a synthetic tube and establishing a high flow pathway for the blood during dialysis. While it's quicker to use after surgery compared to a fistula, it may have higher risk complications like clotting or infection. Finally, we have the central venous catheter, which is a tube that's placed into a large vein, typically in your neck, providing a direct access to your bloodstream. While this method can be used immediately and is often utilized for temporary access, it carries a higher risk of infection and other complications compared to the other methods we described. So in choosing the most appropriate access method, we prioritize your overall health, your dialysis efficiency, your lifestyle considerations, and ensure that the process is as effective and comfortable for you as possible. With that being said, there is some exciting technology coming to the forefront that will help patients and clinicians help communicate and manage your care more effectively about the status and function of their access. For example, Aleo is such a company that is revolutionizing chronic kidney disease management through a non-invasive patient monitoring platform. They have an FDA-cleared smart patch for AV fistulas and grafts. Their hub and clinician portal pathway monitors key vital signs like abnormal potassium levels, hematocrit, hemoglobin, and measures skin temperature and auscultation, the sound of your access. By delivering clinical-grade metrics and actionable insights, Aleo aims to disrupt the normal patterns of care and improve the patient experience, reducing hospitalization and enabling adaptable and personal health management that is scalable. That's exciting news. Hemodialysis access via central venous catheter. Central venous catheter, or CVC, is one of the methods we use to access the bloodstream for hemodialysis. Its significant advantage is immediate usability. If dialysis is needed urgently, a CVC often becomes the preferred choice. It's also beneficial in that it avoids repeated needle sticks, it can be easily placed and removed, and is usually implanted in an outpatient setting, allowing you to return home the same day. However, a CVC is not typically recommended for long-term dialysis due to several drawbacks. The most significant concern is the elevated risk of infection. As the catheter is a foreign object to the body, it can become a site that attracts bacteria, leading to potential infections. Furthermore, it can cause a condition known as central vein stenosis, where there is narrowing of the blood vessels, which could complicate future access options and future possibilities. Having a CVC also necessitates certain lifestyle adjustments. Daily activities that involve water, such as bathing and swimming, may be restricted to minimize the risk of infection. The CVC is typically placed in a large vein in your neck, providing easy and direct access to your bloodstream. And despite its challenges and risks in specific situations, especially when immediate dialysis is required, it's a vital and life-saving option. Well, how about arteriovenous grafts? Well, the AV graft is another method for hemodialysis access. In this procedure, a synthetic tube is used to bridge an artery and a vein, establishing a high-flow circulatory pathway for your blood. One of the primary advantages of an AV graft is its speed of usability. Unlike an arteriovenous fistula, which can require many weeks to mature before it can be used, an AV graft can typically be used for dialysis from a day to a week, depending on which type of graft is selected. This swift readiness makes it a beneficial choice when faster access is needed. The procedure is usually done on an outpatient basis and also enables you to return home on the same day. However, an AV graft does come with its own set of challenges. Since it introduces a foreign body into your system, there's the potential for your body to react adversely to it. Moreover, AV grafts are prone to clotting and infections compared to an AV fistula. They also tend to have a shorter lifespan, requiring more frequent interventions and replacements. Despite these risks, with diligent care, regular monitoring, and professional guidance, an AV graft can serve as an effective and efficient means of hemodialysis access and improve the quality of life for many patients, particularly if they have poor veins and are unable to receive a fistula. Two technologies that hold promise in addressing some of the challenges that I mentioned associated with grafts are Innovasc and Fraxis Intergraft. Innovasc is a groundbreaking or bulletproof type AV graft, which is designed to enhance a patient's experience with cannulation and reduce missed opportunities for successful dialysis. This technology is aiming to improve the durability and function of grafts, making them more reliable and less prone to complications. By offering increased resistance to punctures and leaks, Innovasc has the potential to provide patients with a more comfortable and efficient dialysis experience. Another exciting technology is the Fraxis Intergraft, which introduces the concept of an endovascular anastomosis to maintain the openness of an AV graft, particularly at the graft-vein connection. This technique shows promise in reducing the incidence of graft failure, which often occurs at that critical junction. By employing minimally invasive procedures to reinforce the connection and optimize the flow, Fraxis Intergraft holds potential to extend the lifespan of an AV graft and minimize the need for frequent intervention and replacements. Now, while all these technologies are still in development and require further research and testing, they are offering promising avenues for improving the outcomes and long-term viability of AV grafts. By addressing issues such as cannulation difficulties and graft failure, these advancements have the potential to enhance patient satisfaction, minimize complications, and ultimately improve the overall quality and life for individuals relying on hemodialysis access. The arteriovenous fistula. The AV fistula is often favored as the optimal method for long-term hemodialysis access. During this procedure, a surgeon creates a direct connection between an artery and a vein, typically again in the arm. And this direct connection forms a high-flow circuit that can withstand the regular inflow and outflow of blood during dialysis. The benefits of a fistula are very significant, and it tends to outlast the other forms of access we've discussed thus far, often enduring for many years with appropriate care, thanks to the body's natural ability to heal and maintain its own tissues. Moreover, it does not involve the introduction of foreign materials to the body and reduces the risk of infection, clotting, and adverse reactions are much notably lower. However, the AV fistula is still not without its own challenges. Notably, it requires a maturation period, which ranges somewhere between 1 to 6 months before it can be used for dialysis. And this requires proactive planning and may not be a suitable choice if immediate dialysis access is required. And not all patients happen to be candidates for fistulas. Those who have small or weakened veins may not be suitable for this procedure. And despite these potential hurdles, the AV fistula, due to its longevity, lower risk profile, and overall efficiency, is often the first choice for both patients and physicians when considering long-term hemodialysis access options. Crafting an AV fistula, the surgical and non-surgical methods. Let's explore this for a moment. The construction of an AV fistula, which can be achieved through two primary methods, surgical and non-surgical. What do we mean? The surgical creation is slightly invasive. It involves an incision in the arm to directly connect a vein to an artery, and this procedure necessitates anesthesia and a subsequent recovery period. Despite its invasiveness, it's been the standard of care for many years due to its proven efficacy and longevity. In contrast, the non-surgical creation is a minimally invasive procedure, and it employs specialized devices such as the ellipsis vascular access system and the wavelink system. These innovative devices allow fusion of the vein to the artery without a large incision. And the benefits of this approach are numerous: reduced pain, faster recovery, and the absence of visible scar. However, it's important to note that this technique is relatively new, and not all patients may be candidates for that approach. In both scenarios, the overarching objective remains just the same: establish a reliable and efficient conduit for blood to circulate from your body to the dialysis machine and back to ensure optimal dialysis treatment and improve patient well-being. So let's take a moment to focus on the surgical creation of an AV fistula. This method, as mentioned, has been the standard of care for many, many years, and it's a tried and tested procedure. During the operation, your surgeon makes an incision in your arm, and he connects one of your veins directly to an artery. Now, this procedure is effective. It does come with a longer recovery period. You'll need to care for the surgical incision as it heals, and there'll be a scar once the healing is complete. One of the potential advantages is the creation of a natural conduit, which can ensure an efficient dialysis session. However, it's important to note that there can be complications, such as the formation of an aneurysm, which is a bulging or weak area in the wall of the artery or the vein, and the development of narrow areas that can lead to inefficient dialysis or even clotting and failure. So it's important to always keep your eye on the ball and to feel your access, soft, purr, or thrill, regardless if you have a fistula or graft. And any changes should be brought to the attention of your healthcare team, because that may warrant an intervention to help maintain or even salvage your access. Some innovative technologies that are helping to improve surgical fistula are Sonovex, for example, which offers two key technologies, the EchoMark and the EchoSure, for data collection at dialysis clinics or even a doctor's office to assess an AV fistula or graft's maturation. An EchoMark is an ultrasound marker that helps identify the blood vessels, and the EchoSure automates the detection of flow, diameter, and depth of that access and helps support a physician in identifying an access that is not maturing correctly and needs assistance. There's another device called Vascular that may help address the issue of fistula failure. And it's a scaffold implanted during a fistula creation surgery to protect the newly created access against negative body reactions. Now, the studies recently have shown it reduces the risk of failure, cutting the number of additional procedures by nearly half in the first year, and reducing the time to first fistula use by over a month. Now, that said, with regular checkups and vigilant care, many patients do very, very well with surgically created AV fistulas. As always, though, it's crucial to have a discussion with your healthcare team and understand the pros and cons to see if this method is the right method for you. And in this picture, we have an example of a brachiocephalic fistula. Note the incision, and you can see the venous anatomy, the arterial anatomy, and in different ways where a physician may choose to take vein and attach it to an artery to create an outflow fistula. And similarly, these various sites are the sites that are chosen for minimally invasive endovascular methods, which use the specialized catheters, as mentioned, to fuse artery and vein, and the procedure leaves no scar and reduces complications. So in this instance, when we're talking about a percutaneous fistula, these are innovative techniques, and they allow us to really focus in on two key technologies. One is Medtronic's ellipsis vascular access system, which was developed by Dr. Jeffrey Hall, and it uses a single catheter and ultrasound guidance to create the AV fistula by fusing the proximal radial artery in your forearm to the outflow vein, all done through a needle stick. And the second device, the Wavelink Endo AVF system created by BD, which uses a dual magnetic catheter system to align the artery and vein, and then a small burst of radiofrequency energy to create the fistula, again via two needle sticks. Now, these two minimally invasive procedures have revolutionized the creation of AV fistulas, typically resulting in a shorter recovery and fewer complications than traditional surgery. Here are representative examples of what a percutaneous fistula can look like. You'll notice the absence of a scar and very minimal footprint as identified on the viewer's right, where the forceps in the surgeon's hand can be seen here. Almost indiscernible from a native arm. So let's shift gears for a minute and talk about another type of dialysis, peritoneal dialysis. Now, this method uses your body's peritoneal membrane, which is the lining of your abdomen, as a natural filter. And a special fluid called diacylate is introduced into your abdomen through a catheter. Now, this fluid absorbs waste and excess fluid from your body and then it's drained out of your body. Now, there are several advantages of peritoneal dialysis. First, there are no machines required. All you need is the diacylate solution and your catheter, making it a more flexible option. Because it's a continuous process, it can more closely mimic the natural function of your kidneys. The continuous dialysis can improve your overall well-being. Furthermore, you may have fewer dietary and fluid restrictions compared to hemodialysis. However, peritoneal dialysis does come with its own set of challenges, as do all forms of access. Dialysis needs to be done every day, which may be more time-consuming. The catheter can affect body image, and you may need to make some adjustments in your daily activities, particularly water-based ones, again, like swimming and bathing. And there's also a potential risk of infection from the catheter site. Like all treatments, it's about balancing the advantages and the disadvantages. And more importantly, it's about what works best for you and your lifestyle. Within peritoneal dialysis, there are two main types. First, we have continuous ambulatory peritoneal dialysis, or CAPD. And in this method, the bag is filled with a dialysate solution, which is attached to your catheter, and the solution flows into your peritoneum. It stays there for several hours, during which it draws out the waste and excess fluid. And after this dwell time, the wasted solution is drained back into the bag and discarded. This process, known as an exchange, is repeated 4 to 5 times a day and can be done wherever you feel comfortable, home, work, or even while traveling. The second is automated peritoneal dialysis, or APD, which uses a machine called a cycler. And this machine automatically fills and drains your peritoneum, typically while you sleep. And this allows for more freedom during the day, and as the dialysis occurs mostly at night. Both methods have an advantage, and both are effective ways of performing dialysis. The choice between CAPD and APD depends on, again, your lifestyle, preferences, and your medical condition. As always, it's important to discuss these options with your healthcare team to decide which method is best suited for you. So when it comes to choosing a dialysis option, several factors come into play. And let's take a moment to explore some of them. A patient's health condition. This is paramount. Depending on the severity of your kidney disease and your overall health, some forms of dialysis may be more suitable than others. Your healthcare team will provide guidance based on your specific condition. 2, your home environment. Home dialysis, whether hemodialysis or peritoneal, requires a clean, dedicated space for equipment and treatment. Your home setup and whether modifications are possible or not can influence the choice of a dialysis method. 3rd, your support system. Dialysis requires a commitment and can be physically and emotionally challenging. Having a solid support system, family, friends, or hired caregivers who can assist with treatments or provide emotional support is crucial. Number 4, lifestyle and personal preferences. We've spoken about this a lot, but this is all about you. Your job, your hobbies, your preferences, and daily routine can all impact your choice. You may prefer a treatment that's flexible and can be done at any time, like peritoneal dialysis, or you may feel more comfortable having it done by professionals at a center. You may have a preference for a method that leaves a minimal scar, or you may prioritize one with fewer risks of infection. Remember, it's your body and it's your life. Your comfort and satisfaction with the treatment are critical for success, and you always need to discuss these factors with your healthcare team to help influence both your best decision and the ability of a provider to give you your requested opportunity. So deciding on a course of treatment for a late-stage chronic kidney disease, it's a complex process that depends on your unique circumstances. The decision tree that we have here gives an overview of the choices you might need to make. So spend a minute looking over them as we speak. If you're diagnosed with late-stage chronic kidney disease, your first major decision is between kidney replacement therapy or conservative management, which means an optical medical therapy without dialysis or transplant. If you choose kidney replacement therapy, you have several options. In-center dialysis, and this is where you would visit a dialysis center regularly for your treatments. Then you have the healthcare team, which will manage your dialysis and monitor your progress. Kidney transplant. This is where a healthy kidney from a donor is surgically placed into your body. And this could be a preemptive kidney transplant before dialysis is even needed. Or you might need to start on dialysis while waiting for a suitable organ donor. Home dialysis. If you'd prefer to have your treatments at home, there are two main types. You might consider peritoneal dialysis and home dialysis. Both of these require careful planning and preparation, including arranging the necessary equipment. Remember, every patient's journey is unique, and you might have to move between different treatments as your condition and circumstance change. It's important to have ongoing discussions with your healthcare team to ensure that treatment plan continues to meet your needs. The underlying theme here is continuous dialogue and evolution of your plan. So as we conclude this session, I want to underscore a few very important points. Firstly, the significance of ongoing discussion with your healthcare team, it can't be overstated. Remember, these professionals have a wealth of experience and knowledge to help you through your journey, and they can provide invaluable insights, answer any or all of your questions, and clear any doubts you may have. Secondly, your treatment decision should be informed, considering your personal needs and your preferences. There is no one-size-fits-all approach when it comes to managing kidney disease and dialysis. Every patient is unique, and what works best for one might not work for another. An open, honest communication with your healthcare team will serve you best. Finally, use tools like the infographic that we've discussed today and on this website at AAKP to help you understand your options. It summarizes key points from our discussion and can act as a handy reference. In the end, the most crucial aspect of this process is you, your understanding, your comfort, your well-being. They're at the heart of all these discussions and decisions. I hope the discussion has been informative and helpful for you, and I encourage you to continue seeking information and asking questions. Your proactive involvement with your healthcare can truly make a difference. Thank you very much for allowing me to share time today with you, and I look forward to engaging many of your questions.
Thank you, Dr. Kramer, for sharing this very important information. We'll come back to you during the question and answer period of this webinar. We'll now turn the presentation to our patient speakers to get their perspective on choosing the right access for you. We are joined by AAKP ambassadors Gabi Morales and Melissa Bensuda. We'll start with Ms. Morales. She is a home hemodialysis patient from Tampa, Florida. Ms. Morales was born with one kidney, which had only 10% function. Her father donated a kidney to her when she was 5 years old. The donated kidney lasted until she was 18 years old. Ms. Morales is hopeful that a new kidney is in her future. She's on multiple kidney transplant wait lists in Florida. Welcome, Ms. Morales. I'll turn the presentation over to you.
Hello, thank you. Hi. As Jerome said, my name is Gabi Morales and I'm from Tampa. I have done multiple modalities of dialysis. When I was a child, my parents made the decision, well, when I first started, I went on hemo until my parents made the decision that it wasn't really feasible for me to, one, keep driving to the hospital 3 times a week for them because we were going from Tampa to St. Pete. So they talked to the doctors and decided to put me on PD. So I did PD for about 6 months until I got my transplant from my dad. And then once I got my transplant from my dad and I started on dialysis again 18 years later, I started with hemo with a chest catheter. And as Dr. Kramer was saying, the chest catheter is not ideal because it is very high risk of infection. And, you know, you're restricted a lot between like bathing and swimming and activities that you can do. So I went from the first time I was on hemo, I did PD again. And about after 6 months of being on hemo, and I did PD for about 6 years, and I loved it because it allowed me to live a more normal life. I was working. I would come home, take care of my dogs. You know, you were able to go swimming in, you know, private pools, beaches, as long as you took care of your access and cleaned it properly. I did my treatment at night. And unfortunately, I ended up having to switch over to back to hemo, and I got the CVC in my chest again, and I had that for about a little over a year. And during that time, I got the surgery for a fistula, but my fistula did not mature. So then I made the decision to do a graft, and ever since then, my graft has been functioning properly, and I do um, home hemo with the needles. This is my graft if you'd like to see. It's a little bumpy, um, but yeah. And so the reason why I did that was obviously because the fistula wasn't filled to mature. But also, I was told that it was a better way of living, which it really is. I'm able to do more physically, and I feel pretty great on home hemo, to be honest. Sorry.
I just have one question for you. So where did you learn about your options for your dialysis access options?
I learned about them from my doctor and my parents because when I was younger, my parents, made the executive decision for me. And then once I got older, I realized that I was not a fan of in-center and I wasn't thriving there. And so I just wanted something that would give me um, more livelihood, so that's why I made the decision to do PD. And it also gives you more freedom. Like I said, I was able to go to school and work at the same time, but also set up and be able to come home and do my treatment at night.
And what advice would you give, CKD patients who may be facing, dialysis? What advice would you give them when considering a access option?
Like Dr. Kramer said, I definitely, I wish I did this more in the beginning, is just take into consideration your lifestyle and challenges, changes that you're willing to make with your lifestyle. As far as if you enjoy swimming or going to the beach, I would incorporate those kind of choices in my choosing for my access.
Thank you, Ms. Morales. We appreciate you sharing your perspective. Our
Thank
next
you.
speaker is Melissa Bensuda. Ms. Bensuda was diagnosed with chronic kidney disease after the birth of her second daughter. She lost all kidney function after her third child, a boy, was born. She received a kidney transplant in April 2012 after nearly a 10-year wait. However, 5 years post transplant, Ms. Bensuda's transplant kidney rejected. She now treats using home hemodialysis. Ms. Binsuda joins us to share her kidney journey and her process of selecting her dialysis access. Ms. Binsuda, welcome.
Thank you for having me. Good afternoon. Similar journey. So I actually I started dialysis after my son was born, as Jerome, you mentioned. And at that time, I was fairly young. I had really just taken off in my career and realizing that I wanted the freedom to be able to continue working and enjoying life. And so at the point that I did start dialysis, it was we knew that I would end up on dialysis, but it was in kind of an emergency situation. I became very uremic and needed to start. And so, of course, I started with the catheter. And at the same time that the catheter was inserted, I also had a fistula created. Um, and I had a very lengthy discussion with my doctor about the considerations for catheter. He stressed very clearly that they are higher rates of infection, have higher rates of infection, and that pretty much, as Dr. Kramer mentioned, that the fistula was the gold standard, that my veins and my arteries were in very good condition, and he had no concerns about creating a fistula access. So we did that when I went into surgery, and pretty much as soon as I started dialysis, I was working to get my fistula to be mature, doing different exercises and stretching and things to get that mature because I was very much afraid of getting an infection and being back in the hospital, which I wanted to avoid. So probably 4 to 5 weeks post um, surgery to have the fistula put in, it had matured enough, and I was doing in-center dialysis. I also was not a fan of in-center dialysis. One, because I wanted to work, it didn't fit with my schedule. And the second part of it was that it just took so much time away from my family. I often felt depressed going into the dialysis center. So I started training to stick my own needles in the clinic. And from that point forward, no one else has really put a needle into my access. So I switched to home dialysis, which was a much better fit for my lifestyle. And so this happened in 2002 when I started dialysis. Did 10 years of dialysis, like was mentioned, and got a transplant 10 years later. And when my transplant failed, that was pretty devastating for me. I was very concerned that I would have to have another access put in, because it had been almost 5 years since I had used my access. It turns out that the same fistula was working perfectly. It hadn't shut down or clotted off. And so when my transplant failed, I was able to use the exact same fistula. I'm very fortunate, and I think it's largely because of the care that I've done with my fistula, with proper cleaning techniques, sticking my own needles, for more than 20 or 15 years, I guess you could say, and being careful about carrying heavy objects. But I've been able to have this same fistula since 2002, and currently use it up until today. And I've only had one surgery on the fistula, which was to remove aneurysms that had grown pretty large over time. I do regularly listen for the blood flow. I won't say each treatment, but a couple times a week I check for the blood flow to make sure that I hear the pulsation and the thrill. And there have been about 5 instances over the 20 years that I've had, some narrowing that needed to be opened up. But overall, I'm very grateful to say that I've always been able to use the same fistula, and I hope that it continues. Proper care to me has really been the important thing. Limiting the number of people that have stuck needles in my arm, just being in tune with my body, and then having regular communication with my medical staff has really been what's helped me to keep the same fistula and keep the same modality of dialysis to this point.
And I'll ask you the same question that I asked Ms. Morales. What advice would you give to someone who may be starting dialysis soon and needs to start thinking about a fistula or an access?
So I have the same, suggestion as Ms. Morales is, think about the lifestyle that you want to live, and then choose your access or modality based on that. There are many more options, even some that I learned on this webinar about options for, putting in access. And I say explore those, get the information about each of them, see where it fits into your lifestyle, because dialysis, you don't have to live around dialysis. Dialysis can fit into your life, and you want to do what's best based on what you want to accomplish and achieve in life.
Thank you, Ms. Bensuda, for sharing your story with us. We have a few questions that people submitted when they registered for today's webinar that I'm hoping our panelists can answer. Our first question is for Dr. Kramer. With all the innovations in dialysis access happening, how do I know what's the best option is for me?
Well, I think that's kind of a loaded. That's a kind of a difficult, loaded question. It's a great question. I think the best one is honestly a discussion with your healthcare providers. And that starts with I think you're a nephrologist on the front end to understand your home environment, to understand, when you're going to select a modality, where you're going to be able to manage it. So some people, for example, if they wanted to do home dialysis, which there's a lot of emphasis in the world today for people to be at home, and that's a great desire. But if you were going to do PD and you don't have dexterity in your fingers and your sight is poor, that can create challenges both for self-cannulation as well as for peritoneal dialysis at home. So without the appropriate support at home, that therapy might not be your best opportunity, and there might be less risky opportunities or less difficult roads to travel, let's just say. Other parts of what is right would be your own anatomy. So while you may have a great home environment, are you the best host for having the therapy that you would desire? So if you've had previous operations of your belly, for example, some of those can create adhesions inside your belly, which might reduce the ability for you to get an appropriate catheter placed. If you have had multiple surgeries in your extremities, that similarly can create some challenges. And if you have advanced atherosclerotic disease and things like this, for example, that access might also become challenging. And so switching from one modality to another modality is an ongoing dialogue, truly not just based on what you want, but the shifting sands that is your own body and your own biology as you age, as we age into new illness, as we recover from illness. The whole dynamic shifts. And so this is an ongoing discussion at all times, and it's based completely on you and where you're trying to be.
Thank you, Dr. Kramer. We do have another question for you, and it is, I have
Yes, sir.
I have catheters due to 2 failed grafts that do not work. I understand that this is extremely risky. What can I do to avoid additional risk?
Well, again, I'd default to the question that we just had previously. I think if when patients come see me, let's start here. If patients are coming to see me and they've had 2 failed grafts and they're dialyzing with a central venous catheter, I'd like to know the duration that the catheter has been in place. The second thing that I'd like to know is, are there options in the upper extremities or lower extremities that might allow us to shift from catheter-based dialysis if hemodialysis is the continued desire? So that would include things like vein mapping, potentially CT scans of the chest, and central venography to visualize and actually inspect these veins. It would also allow us to use duplex ultrasound to assess the inflow or arterial delivery to that access to see if that's going to be favorable. Another part of that evaluation would be to understand, why are these accesses clotting? If you have a clotting disorder, is that something that can be mitigated, or can we reduce the risk of blood clotting by adding blood thinners of some variety to your regimen to help support you getting hemodialysis if that's the option? If, for example, we can't go down that road for a host of reasons, well, then perhaps switching therapy to peritoneal dialysis would be a better decision than staying long-term with a tunneled central venous catheter. So it's always measuring where you are, what the next best therapy is, and trying to enhance your opportunity for successful dialysis and more healthful dialysis in a setting that fits you and your needs.
Thank you, Dr. Kramer. This next question is for our patient speakers, and we'll start with Gabi. How do you choose or change what access you have or had?
Well, the decision was made for me. I ended up getting a bacterial infection in my PD catheter after 6 years. And so we just weren't able to reverse it. And by the time that we went back in to see if I was eligible for a new catheter, like Dr. Kramer said, I have had too many adhesions, so I wasn't longer a candidate for PD. So at that point, it was in center hemo or home hemo. And so I decided on home hemo at that point.
Thank you, Gabby. The same question to Melissa. How do you choose or change what access you have or had?
So I actually haven't changed. I mean, I started with a catheter and knew that that was always going to be a short-term option for me. And then we switched to the fistula, which had been created at the same time the catheter was placed. And so, that decision was based on extensive conversations with the medical team to understand what my options were, what would give me the best long-term results with minimal changes, at least anticipated anyway.
Thank you both for those responses. The next question is for Dr. Kramer. Which access do you think lasts longest?
The one that's cared for the best is the honest answer. I think if you take all comers, there's a reason that AV fistula remains the gold standard of care. Typically, these have the longest durability because, again, this is your own tissue and your own body. So your body does have the ability to heal itself. It has its own immune response. And so your risk of infection is much reduced because you can heal yourself more readily than any foreign body. Your risk of loss of access is much lower. Regardless of the type of access that you have, it demands vigilance and it demands a constant attention and a constant growing amount of education about how to care for your access. And I really think that, webinars like this, patient portals and information that can be provided through context, the way we're sharing information is truly the best way to ensure that the access lasts the longest. Certainly there are technologies which we've referenced that can help in prolonging access life and reduce the number of interventions like balloon angioplasty or covered stenting, declotting accesses that have failed, or revising PD catheters, etc., which are failing. That being said, without the patient being a self-advocate, without bringing the complaints or concerns to a physician in a timely manner, and allowing others to take responsibility for our care independent of our own input, I think is a tragic mistake, because nobody's going to care for you the way you care for you, and no one is going to be aware of the changes in your access that you will be aware of. And it remains imperative to remember that this is your health and that your access, no matter what the chosen pathway is your access, and it is your lifeline. And I would never turn that responsibility over to anyone else other than myself or a loved one in my family to take chief interest to make sure that it is functioning correctly and continue to grow and educate ourselves in that maintenance, so that when we talk to healthcare providers, they're aware of the changes and you can be treated in a timely manner and not delay your care.
Thank you, Dr. Kramer, Ms. Morales, and Ms. Bensuda. Your presentations were very informative today. If anyone watching has additional questions for our speakers or about today's webinar that we were unable to get to, please send those questions to info@aakp.org, noting the webinar title in the email subject line. I'd like to close today's webinar with a few slides on additional resources that may be of interest to you. If you are not already a member of AAKP, we encourage you to join. AAKP offers free memberships to patients and their family members, as well as living kidney donors. To become a free member, join online at aakp.org or by phone by calling 1-800-749-2257. To receive all the benefits of membership, please be sure to include your email address when signing up. As an AAKP member, you'll be notified by email when opportunities arise where your opinion and experiences are needed to help inform innovation, advance care, and make meaningful impact to improve lives. We encourage you to respond to our flash surveys and other engagement opportunities to help us elevate the patient voice and change the status quo for kidney disease care. You can also select to receive any of our 5 different electronic newsletters and subscribe to our printed magazine, AAKP Renal Life. We also invite you to follow us on our blog and social media for all the latest news and announcements. AAKP is dedicated to helping kidney patients across the disease spectrum understand their condition and take control of their health care. We are proud to offer a variety of resources for both patients and care partners. By visiting our website at aakp.org and clicking on the AAKP Store button at the top of the homepage, you can find a variety of educational brochures and online tools to order or download, including our Understanding Your Hemodialysis Access Option brochure and our conversation starters, questions to ask your healthcare team about choosing the right therapy for you, and or questions to ask your healthcare team about changing dialysis therapies. You can also order materials by phone. We are excited to announce the dates of our 2023 event, the 5th Annual Global Summit on Kidney Disease Innovations in partnership with George Washington University School of Medicine and Health Sciences will be a hybrid event, both online and in person, in Washington, D.C., and will take place June 28th and 29th. The 6th Annual Policy Summit will take place virtually on July 28th. The 48th Annual National Patient Meeting will take place virtually September 20th through the 22nd, and the 5th Annual AAKP Fun Walk will take place virtually December 4th through the 8th, with an in-person walk in Tampa, Florida on December 9th. We invite you to let us know which events you are interested participating in this year, and we'll be sure to notify you when registration is open. You can also visit our YouTube channel to watch presentations on demand from our 2022 events and programs. As we close, we'd like to thank Medtronic for providing an educational donation to support this webinar. And again, we'd like to thank Dr. Ari Kramer, Gabi Morales, Melissa Bensuda for participating in today's AAKP HealthLine webinar. Thank you all for joining us today.